Assalamu alaikum. Today I'm going to read AKP clinical case number 26, that is a 5-year-old girl with wrist pain. This case describes a 5-year-old girl with episodic pain and stiffness affecting multiple joints including the wrist, ankles and right knee over a 6-week period. She also has a history of right knee swelling a year ago, which was initially attributed to trauma but has since been followed by multiple episodes of joint pain and swelling. Her clinical examination reveals swelling without erythema in her right knee and left wrist, limited movement in multiple joints, pale appearance possibly indicating chronic inflammation or anemia, no dermatological abnormalities, mildly raised temperature which is within normal limits but may suggest chronic inflammation. Her investigations provide several important clues that help in understanding her condition. The hemoglobin level is 98, which is lower than normal range for children of her age, indicating anemia. This is commonly seen in inflammatory conditions like juvenile arthritis. The MCV, which is below the reference range, suggesting microcytic anemia, which would be result of chronic inflammation or in some cases iron deficiency. The MCH is also low, which further supports the idea of microcytic anemia as the red blood cells contain less hemoglobin. The MCHC also below the normal reference range, further indicating that the red blood cells are hypochromic and contain less hemoglobin than usual. The WBC count is elevated, suggesting an ongoing inflammatory or infectious process. The platelet count is also high, which is another common sign of inflammation and can be seen in autoimmune conditions like juvenile arthritis. ESR is markedly elevated, which is a strong indication of active inflammation in the body. This result is often elevated in conditions like juvenile idiopathic arthritis, where there is inflammation in multiple joints. The CRP is also raised, which further supports the presence of inflammation as CRP level raise in response to inflammatory cytokines. The negative rheumatoid factor and negative ANA test are both important results. A negative rheumatoid factor makes a diagnosis of rheumatoid arthritis in adults less likely, as rheumatoid factor is usually positive in adult rheumatoid arthritis. The negative ANA result suggests systemic lupus erythematosus is less likely, as ANA is typically positive in most cases of SLE. However, ANA negative does not rule out juvenile idiopathic arthritis, particularly the polyarticular form, as many children with juvenile idiopathic arthritis, especially those who are rheumatoid factor negative, can have a negative ANA result. Overall, these blood test results support the diagnosis of polyarticular juvenile arthritis, characterized by elevated inflammatory marker, anemia of chronic disease, and negative rheumatoid factor and ANA. The inflammatory marker like ESR and CRP being elevated along with the microcytic anemia fit well with the clinical presentation of a child with multiple joint involvement and inflammation. Polyarticular juvenile arthritis is the most common chronic inflammatory arthritis in children under 16 and lasts for at least 6 weeks. The presence of multiple joint involvement, especially wrist, ankles, and knees, fits the profile for polyarticular juvenile idiopathic arthritis, which affects 5 or more joints. In polyarticular juvenile idiopathic arthritis, joint pain and swelling may be episodic, and the child might experience morning stiffness or pain, while some children can have joint swelling without significant redness, as seen here in this case. The limitation in joint movement suggests chronic inflammation. The raised ESR and CRP combined with anemia suggest an inflammatory process which is typical in juvenile inflammatory arthritis. Here is the first question asked in this case is, what is the likely diagnosis? Select one answer only. Let's rule out one by one. First option is ankylosing spondylitis. Ankylosing spondylitis is a form of inflammatory arthritis that primarily affects the spine and sacroiliac joints, leading to pain and stiffness. It is more common in older children and adolescents with a predilection for the lower back and pelvis. While this child does have some limitation of neck movement and the absence of lower back or sacroiliac pain along with the multiple joint involvement makes ankylosing spondylitis unlikely. Next option is Lyme disease. Lyme disease could cause joint pain, especially in knees, and swelling often associated with history of tick bite, erythema migrans, and a seasonal pattern. However, the absence of such a history along with no dermatological features or neurological signs of Lyme disease makes this diagnosis unlikely. Additionally, Lyme disease does not typically cause the wide range of joint involvement like seen here in this case. Next option is systemic juvenile arthritis. Systemic juvenile arthritis is another form of juvenile idiopathic arthritis that typically present with a high fever, rash, and systemic symptoms like lymphadenopathy or hepatosplenomegaly, none of which are present in this case. Although the child does have joint inflammation, the absence of systemic features makes systemic juvenile arthritis less likely. Next option is systemic lupus erythematosus. SLE is another autoimmune condition that can cause joint pain, but it is often accompanied by other systemic features such as butterfly-shaped facial rash, photosensitivity, and kidney involvement. The absence of such features, coupled with chronic and episodic nature of the joint inflammation, SLE is unlikely. So the diagnosis is polyarticular juvenile arthritis that is most fitted with these symptoms. Next question is, which is the next most important investigation? Select one answer only. Let's rule out one by one. First option is Borrelia burgdorferi titers. This test is used to diagnose Lyme disease, which is caused by the bacteria Borrelia burgdorferi and typically transmitted by ticks. Lyme disease can be present with arthritis, especially in children, but it typically affects a single joint, usually the knee, and would not explain the multiple joint involvement like seen here. Next option is echocardiography. Echocardiography may be needed in certain conditions such as SLE or systemic juvenile arthritis, where there can be associated heart complications. There are no signs of heart involvement in this child's presentation, and lab findings supports an inflammatory joint diseases rather than cardiac issues. Next option is ECG. ECG would not be appropriate here because the child's primary symptoms are related to her joints and there are no signs of cardiovascular involvement. Next option is lung function testing. Lung function tests are used to assess how well the lungs are working and can help diagnose conditions like asthma or COPD. This child's symptoms are joint related, so lung function testing is not relevant here. Next is plain X-ray of affected joints. Although X-ray can be useful in assessing joint damage, especially in case of juvenile idiopathic arthritis, where chronic inflammation can lead to joint destruction, they are usually not necessary in early stages of the disease. In early phase, the X-ray might appear normal. Therefore, it might be used later to assess joint damage. So that is not the next most important test at this stage. So the most important next investigation in this case is a slit lamp examination to screen for uveitis, a potential complication of juvenile idiopathic arthritis. Uveitis in juvenile idiopathic arthritis can be asymptomatic, meaning the child may not represent any vision problems or pain. However, it can lead to serious complications like cataract or glaucoma if left untreated. Regular screening for uveitis with slit lamp is necessary even in the absence of ocular symptoms because early detection can prevent long-term eye damage. Thank you for watching. This is all about from this case. If you have any question, comment below, like, subscribe and share.